I don't want to leave this topic without touching briefly on knee replacement surgery, because this is sort of the final common pathway for people who get really sick. You've already talked about when you shouldn't do it. When should you do it? What is the indication for it?
So again, lifestyle has become the major driver in joint replacement. The age of intervention continues to get lower. The operation continues to get better, less complications. Expectations are higher. Patients want to do more. They want this to last longer. We can pretty much guarantee people, if they behave themselves appropriately and they don't get sick or have a fracture or an infection, that these things will last for 20 years or perhaps longer. What we can ensure is that we're completely reduplicating original knee function. It's a really good substitute. It's not the same one as God gave you. You're not going to automatically become 29 again. So I go back to what I said earlier. If you're having symptoms that are unresponsive to conservative treatment, if you can't do the things that make you the person you want to be, if you can't go to work in the morning, you can't get pain relief at night to sleep, or you're having instability or giving way episodes, you may very well be a candidate for knee replacement.
Those are the benefits you talked about. What are the risks of this operation?
Well, I think one of the things that is the motivation for the remainder of the conversation that we've had is that there is large registry data that suggests that roughly 20% of patients are not satisfied with their pain and function after total knee replacement. We look at their x-rays, we look at their clinical function, we say, knee looks good but feels bad. And that's a challenge for us. And that's really the motivation to sort of delay that joint replacement until patients are really ready for it with all the symptoms that Rich described and have realistic expectations. Up to a third of those patients have residual symptoms of some sort after knee replacement. So I think it's something that those are certainly some of the risks of outcome. We talk about all the other risks of infection and cardiovascular issues around the time of surgery. But overall, I think our risk profile is really quite low in terms of giving patients a really successful game-changing outcome in the patients who are successful with this.
So I think we know that there are groups of patients who don't do as well as we'd like with knee replacement. Those patients who have depression on medication, those patients with very high anxiety or catastrophizing behaviors, those patients with fibromyalgia, other comorbidities, they just don't seem to do as well, even if they don't have a major complication or you try to give them realistic expectations. But I think it is a valuable tool. We certainly, as Rich mentioned, we're doing a lot of knee arthroplasties. But again, I think the take-home message for patients are that this is not a normal knee. It's pretty good, but it's not a normal knee.